This is, given that it's close to post-COVID, a bit of a hybrid meeting. Welcome, please step up. So I wonder if our technical friends at the back can get us connected to Minister Coopers. He's not coming. Okay. Hybrid meeting, a bit of change of plans. He is being delayed, and he may be late, or he may not come. So we will improvise it. We will sort that. So I want to share a few thoughts first on this session, on the role of policymakers, the regulators, as I indicated on the previous slide. And so the first thing I'd like to share with you is the notion of healthcare status today and the logic of what we call the value crisis, or the three crises that we think healthcare systems face today. The first one is what we call the value crisis. Healthcare spending is growing twice the rate of GDP growth, so a larger and larger share of all the services and products in society are healthcare. And yet we know from work of OECD and WHO and others that maybe 20 to 40% of what we do is wasted. 20 to 40% doesn't help patients. So that's a value crisis. The second one we call an evidence crisis. We are growing R&D spend in healthcare worldwide at about 5% per year. But a smaller and smaller share of that is actually generating evidence that we need for guidelines, that we need for clinical decision-making. More and more of the research is going into very specific and focused and siloed questions. And there's a big deficit in the type of evidence we need for decision-making in a world where medicine and healthcare becomes more and more complex. And thirdly, and maybe the most damaging and disturbing, is what we call a purpose crisis. Across the world, even before COVID, we see a growing number of doctors and nurses burning out, leaving the profession, or considering to leave the profession, a profession which definitely needs all these dedicated and highly educated staff. And this we see, these three crises, we don't see in Finland and then maybe somewhere else. We see it ubiquitously. And we spoke about this in a session just before. We see it in Singapore, we see it in Germany, we see it in the US, we see it elsewhere. It is a common set of challenges across healthcare. And therefore, there must be some common principles we can address to, or to deal with, to address those. The purpose crisis is not because doctors no longer have free coffee or don't have fruit baskets in the pause room. It's much more fundamental, and it's important that we look at the fundamental reasons for it. You saw this slide before. We said there are 4 levers of changing a system. It's interesting how that changes by itself. Today, in this panel, we're focusing on the policy side of this. How prescriptive should policymakers be to transform healthcare? Will this happen by itself? Or do we need a moonshot initiative in nations where you invest heavily behind big transformational change, obligatory outcomes measurement, platforms for new types of clinical research, etc.? So what is the balance between pushing and being more observing of the system? Now that Ernst Kuipers isn't joining, I'll share with you what he said. He said to me that in the past, the government has been a bit like the audience in a hockey game. They should actually be the referee and should be active in defining the roles. But often nowadays, they sit and look at the game and try to see, have a general view on the game. His view is they need to be much more active. But we'll come back to that in our discussion. Now, to address these questions, we have a fantastic panel. And here's the panel. So the first two, or in this case, the first person is the Minister of Health from the Basque County in Spain, Odzonis Sagordui. Yep. Second from your right, Ernst Kuipers is the Minister of Health in Netherlands. He used to be the CEO of Netherlands' largest university hospital. We will see if he's able to join. If not, I can bring in some of the perspectives he mentioned when we spoke. And then we have three officials who are not politically appointed, but appointed to make it happen, and in different ways and from different geographies. So we have Daphne Koh, who is a senior official for the Ministry of Health in Singapore, and leads, is Deputy Director of the Medical Services, and leads the Health Performance Group that is involved in the biggest transformation of healthcare in Singapore since several decades back. We have Purva Raval, to your right, who is the Chief Strategy Officer of CMMI, or CMS Innovation Center. The body in the United States that's been given the mandate and resources to drive change, to test and innovate how to transform the healthcare system. And finally, we have Dana Safran, closest to me. Dana leads the organization NQF, which validates quality measurements for CMS, and therefore plays a very important role in defining how do we measure quality in the United States healthcare system. And she was previously with Blue Cross Blue Shield and played a very central role in Massachusetts in payment reform there, which influenced what the US government or CMS has done since. So what I'd like to do first is to ask each one of you to share 5 minutes on your perspective on the role of governments and your particular experience. And after that, we have a set of topics that I'd like to discuss with you. And so I think originally I had planned that Professor Kuipers would start. Oh, he is there. That's amazing. That's very good timing. So Ernst, we have just done introductions, and I did introduce you.
Thank you.
You don't know what I said, though. Yeah. But I'd like to hand over to you, Ernst, maybe to give your first 5 minutes remarks on your thoughts on the role of government, and particularly now in your relatively new role as the minister from having been the CEO of a hospital before.
Yeah, well, thank you very much. And it's my pleasure to join you, even when it's from a distance. We've collaborated, Stefan and I go back a long time, indeed from the time that I was a CEO of a large university hospital here in the Netherlands, and we had many good discussions. And so it's a pleasure to join. It's also a pleasure to share our strategy to ensure that every patient at every time has access to high quality healthcare. Some of the discussions that Stefan and I had over the years found their way to his book, The Patient Priority, and I really encourage you to read it. And of course, do not skip the parts which are about the Netherlands. Because as you probably know or can read in his book, we started a program several years ago to implement what we called outcome-based healthcare, and we did so on a national scale. When the program started 4 years ago in 2018, we set a target to have outcomes available for 50% of the burden of disease by the end of 2022, so the end of this year. For the importance of patient-reported outcomes, we were inspired by ICHOM, and therefore decided to use clinical and patient-reported outcomes to enrich shared decision-making. And despite COVID, which kept us, like everywhere else in the world, very, very busy, we came a long way. And we may touch upon that later, but we realized that implementation, even more so on a national scale, is hard and is also highly dependent on connectivity and on ICT systems. Now, as you may know, we have in the Netherlands since long several high-quality registries, excellent registries, but it takes time to further mature and add to that all the things that we needed for this particular program, and also to gain the trust from all the professionals that the information that they get back is actually reliable and actually reflecting their situation, the patient situation, as well as the comparison with others. That is by itself not enough. We also know that not all patients, even in the Netherlands, do have access to high quality care. And this does impact the overall outcome in many different fields, whether it's emergency medicine, pediatric care, oncology care, primary care, etc. Now, in that respect, I'm very proud to share that what I did over the past 10 months when starting as a Minister of Health, coming from healthcare itself, we focused very much on achieving and getting to an overall and integrated care agreement with all the relevant stakeholders in healthcare, starting with patient organizations, also starting with local authorities like city councils, but of course also with primary care, hospital care, nurses organization, physician organizations, health insurers, mental health care, long-term care, so many different parties. And we indeed came with a very, very comprehensive agreement containing actions from diagnosis to palliative care and from shared decision-making to the mandatory health insurance. It gave us a multi-year work agenda across domains in healthcare, putting a patient first, and also, as I mentioned, with the in close conjunction, for instance, with local government and with health insurers. As I can give you a few examples, we agreed to radically improve regional cooperation, including all the IT systems that are needed for that, to ensure that every patient has access to high quality healthcare, access to excellent technology and capacity. Where needed, we are also now concentrating low volume, high risk and high complexity treatments, and are also from government side enforcing minimal volumes for teams to be treated and taken to diagnosis every year. That also means that we are reshaping emergency medicine. It's however not only with a focus on patients, but of course also with a very important focus on our workforce. Our workforce faces the same issues that you do basically everywhere in the world. Major issues with respect to staff attrition, with major burden due to COVID, postponed treatments and waiting times, and many, many constraints. So as a government and as a minister, I have to give guidance and I have to facilitate that this all works out. So I look forward to the further discussion. Thank you very much, Stefan.
Thank you. I think maybe we move over to Minister Sagardui from Basque to share your challenges and what your focus areas are and how you see the role of governments in reforming healthcare systems.
Well, good morning, everybody, and thank you very much for giving us, as the Basque government, the opportunity of joining you in this meeting. No, I think that first I may share with you some small points about where the Basque country is. No, I'm sure that a lot of you know that it is a region up in the north of Spain, very near to France, and that makes a difference because we are always willing to look up to Europe. We have a population of 2.1 million people, and we have been developing and running our own public health system for the last 40 years, independent from the Spanish government and also absolutely different to other Spanish regions systems. 90% of the health care in the Basque country is absolutely public. It means that we can guarantee equity and universality to all our population in terms of health care. Even if the Spanish government has got the duty of coordinating the different health systems of the regions in Spain, the main difference in the Basque country is that we have freedom to collect our own taxes, and it means that we have our own budget, no, in our territory, and for preventing all the public services in the territory. It may be not a big difference, but it makes really a big difference in terms of practicity. Why? Because It means that we are able to support the highest investment in research and development in whole Spain, nearly at the same level as in Europe, over 2% of our PAB. We claim as regional government that we are for a more active dialogue in Europe among regions instead of countries. Also about health, and why we claim for that, because we highly believe that the decisions discussed in European level are more useful for the citizens. And we regional governments are the ones who are nearer to the citizens. We are the ones who know about the needs and also who take care of them, who provide them of solutions. I think that that was the clue, that was really the success of the vaccination against COVID-19 in Spain. You know that we have one of the highest percentages of population vaccinated, completely with all the doses. But of course, we have features in our system. Which are those features? Universality, equity, solidarity, quality, and participation. Participation of our professionals, but also of our patients. Everybody who lives in the Basque Country has the right, not a chance, which is the difference, but the right to be attended by the public health system for free. It doesn't matter whether you have been living there for a long time or for a short time. It doesn't matter how much money you are earning or if you are in unemployment. No, it's just that you are a person and we have to take care of your health, whoever and whenever you are in our country. I would say, in short, that our system is based in a human being. We are persons looking after persons, no? Each citizen also has got his or her reference practitioner, who is the person who is going to follow all his life since he or she is born, since the last days in his life. And then he will be the one, or she will be the one, because we've got most of our practitioners are women nowadays, hopefully, and also most of our nurses. That's something that I also think makes a difference in a kind of system that you build, a big difference, no? And those are the ones that go directing whether you have the need for hospital care, for emergency care, or whatever it is, no? The medical, the nursing attention is, I repeat it, and I repeat it because I wanted to make clear, free for everyone from any level, since primary level, since hospitalization, since emergency, even when we are talking about complicated therapies or even about drugs, where mostly the payment is also public. How are we able to do that? Because during these 40 years that I am telling you about, we have been decided that our budget should be directed to the care of persons. And when you are talking about being centered in the person, you are talking in a huge amount about taking care of the care of their health. You know, 31% of the budget of our government, the Basque government, is dedicated to health care. Even among or during the crisis, the health department budget has been growing and growing, which it doesn't mean, and you mentioned it that previously, that that's the right thing to do, but it's important that you have that, that very clear. That is not a kind of wasting money, it's a kind of investing money in your population, no? And but we have goals, of course we have them for the future, and I think they are very important. Which are those? One of them is the lack of professionals, especially at primary level nowadays, but in the next years that will be a continuous if we are not able to react very quickly. Also, I would say that the lack of professionals interested in isolated areas of the city. Now, new generation are more decided to work in the big cities. They want to have their own project of life. They want to specialize, most of them. And I think that as societies, we have to think about that, because that's Why is happening that? Maybe because we are not giving the importance that is owed to the primary practitioners. Is that the reason? Could be that one of the reasons? Also, the sustainability of the system. That's why since 2016, we started with different projects following the ICHOM methodology in different pathologies such as stroke, breast cancer, lung cancer, and e-cataracts. Now, we already know unit costs per patient. We know the opinion of our patients, and we have from some prims from them. No, but we would want to go a little bit further. We would want to improve a value-based basic care system in the Basque Country. It's not going to be easy, I know. It has to be worked in different levels, professional level, society level, political decision levels also are involved, but we are convinced that it will be fundamental for the future of our system if we want it to be of quality and universal.
Excellent, thank you. So I'd like then to move from Europe eastwards, and Daphne, to hear some of your thoughts on the role of the government in driving change. The Singaporean system is undergoing a very, very significant change program at the moment.
Thank you. First of all, I'd like to thank the organizers for giving Singapore the opportunity to present what changes are happening in our country. And I would like to say it was really good to see some familiar faces from value-based healthcare over the past couple of years at this conference today. The value-based healthcare journey for Singapore started around 2016, when in 2016 we announced our 3 Beyond strategy. And the 3 Beyond strategy in Singapore was, the first was moving beyond healthcare to health, so greater emphasis on preventative health. The second was moving beyond hospital to community, which was really focusing on community care rather than acute hospital care, which has been Singapore's traditional strength. And the third was moving beyond quality to value, and was really talking about, it's not about just the quality of healthcare, but really, given the cost of the healthcare, is that healthcare really worth it? So that was a really seminal mindset shift. And around the same time, in 2015, 2016, we set up our National Health Technology Agency, which began to then measure the cost effectiveness of various technologies. Now, I would say in Singapore, there are 3 main areas that we worry about. The first, of course, is the rising cost. As many people know, relative to GDP, Singapore is one of the most efficient countries in the world in how we spend our healthcare dollar. In terms of, we have one of the longest life expectancies, and the percentage of GDP that we spend on healthcare is around only 4%, which is good relative to most countries. However, as Stefan has previously mentioned, the problem we're seeing is that the growth in life expectancy is not commensurate with the increase in healthcare costs. Healthcare costs are increasing rapidly. 2 main drivers of healthcare costs. One is manpower, the second is health technologies, particularly cancer drugs, cell and gene therapy. And I'm sure that every country is dealing with these issues. So really it's, the cost management strategies that come in that space. The second is really the complexity of healthcare and of patients as the population ages. So it used to be in Singapore that 50 years ago, people would die of an infectious disease when they were 60 years old. And now you're seeing people live till our life expectancy is 84. In a couple of decades, you're going to see that go to 90. And so, how are you going to pay for this healthcare? And Singapore is also a regional hub for clinical excellence, which means that we do have to offer the latest and the best of technologies, but how do you do this at affordable price points? So I think, and of course, the whole move to specialist care. I met someone the other day who told me her father is seeing 27 specialists. Right? This cannot continue. Cannot continue. So, which is one of the reasons why for this year, our minister has announced the Healthier SG strategy, which is again, a very, very transformative movement for Singapore. And this is really about every Singapore resident being now enrolled to one of our 3 healthcare clusters and having a primary care physician to coordinate the massive amounts of care that our older patients with multiple conditions require. We talked about the manpower issues. I think manpower issues, particularly in COVID, are facing, all countries are facing the manpower crunch. I was very interested to hear from the Minister of the Basque County that there's no problems with nurses. I mean, that's unheard of in our part of the world. Every country in Asia is probably, with exception of maybe places like Hong Kong, are suffering from a really critical shortage of nurses. And again, in terms of doctors, what are the kinds of doctors that we need going forward, given the sort of different population that we're going to have, one that's going to live much longer with chronic conditions. So that's the reasons for some of the transformations that have been happening. In terms of value-based care, in 2017, we rolled out 17 conditions, which account for about 30% of the total volume of care that's in the public sector. And here we are measuring the outcomes and the costs at individual clinician level. Now, that's easier to do for very discrete diseases. But as you're talking about the diseases which cost a lot, like cancer, end-of-life care, or diabetes over the long term, I think actually measuring thinking about the core measurement sets and how you count the costs is actually much more complicated to do than with procedures. So we're moving now into the new value-driven care stream that we'll be rolling out in the not too distant future is end of life, which is a very, very complicated one to do. So I think that quickly summarizes all the work that we're doing. We've really made a lot of progress in the culture change. When I joined the ministry in 2014, people said, don't mention the words value-based care and cost effectiveness because people don't like it. But I think now it's just in the language. I also want to acknowledge my boss, the Director of Medical Services, Professor Kenneth Mark, who's in the audience, who has also supported a lot of the work that we do.
Wonderful.
Thank you.
Thank you. I want to encourage you all to write down a few questions. We hope to send around microphones. Some good questions will be good towards the end. I'd like to hand over now to Dr. Raval. You lead the strategy team of CMMI. I mentioned the word moonshot, investing heavily to rethink and enable change. I think CMMI got that mandate 10 years ago. You actually are also moving into the second decade, just as ICHOM does. But I'd like to hear your thoughts on the role of the government in funding innovation, but also in actively driving change on the basis of the experience you've had over the past 10 years.
Absolutely. First, I'll just say good morning. I'm excited to be here with you all today in person. I know our Deputy Administrator and Director of the Innovation Center, Liz Fowler, is going to be joining you all on a panel this afternoon. So hopefully I'm going to tee up some of what she's going to talk about without stealing any of her thunder. I want to say thank you to Stefan and the international and national leaders here that I'm sitting here with today. We had the pleasure of meeting with the Singapore delegation earlier this year to hear about their work and their journey, and even just hearing some of the themes that you talked about in the first hour of the morning. The Innovation Center is just like ICHOM. We are in our second decade and really looking at the lessons learned from the first decade to inform where we want to go moving forward. And I think what really struck out to me in all of the comments so far in this morning is this shared commitment to building a health system that's really focused on improving patient outcomes, patient health, and the patient experience, and value-based payment being a mechanism for us to be able to do that. As Stefan said, the Innovation Centers really was mandated as part of the Affordable Care Act over 10 years ago to initiate that kind of change at the national level. And what we've done over the last year and a half is really taken stock of those lessons learned. We've launched over 50 models in that first decade. I'll talk a little bit about some of the lessons learned that are informing our work going forward. But our reach has been really extensive. From 2018 to 2020, we served over 28 million beneficiaries, and we had over 500,000 providers and plans participating in our models. And so we know that when we are testing an innovation, the market is paying attention, and oftentimes we have broader impacts, transformational impacts on the system. But it's really important for us moving forward to take those lessons learned, to understand our impact, and then to help build a health system that results in more equitable, affordable, high-quality, person-centered care. I'll start by just, when Liz Fowler took over about a year and a half ago, one of the first things that she did was say, let's take stock again of those lessons learned from the last decade, and let's chart that path forward for the next decade. And so I'll talk a little bit about some of the major lessons that we did learn, both in our internal review of our models, but also in speaking to a number of external experts as well, who really wanted to say, what should the Innovation Center really be focused on in this next decade? The first one was equity, and the fact that there wasn't really a focus on equity across all of our models. And I think this was a really important point in the US, especially when we saw the differential impacts of COVID on underserved populations. So that was a very important lesson, that we needed to be more intentional about promoting equity through our models. I think the other was streamlining our portfolio. We had over 50 models. We're operating over 25 still. That creates a lot of complexity, especially for those organizations, hospitals, health systems, providers that might be in multiple different models. And that's just what CMS is running. We also have commercial payers in the United States. We have Medicaid and states, and many of them are also operating value-based payment models, as many of you know. And that creates complexity. There's overlap. And so one of the things we really want to be doing is saying, what did we learn again from that first decade? What do we know, or what are we starting to understand works, and how do we streamline that portfolio to reduce that complexity, overlap, and burden? I think the other lesson learned was care delivery, that the care delivery infrastructure is critical, and the payment changes are intended to support that care delivery infrastructure that results in better patient outcomes. And that means that we learned that organizations, providers that are participating in our models, they often have to make really significant investments, and we need to be aware and mindful and supportive of those investments. And there's always a question in the US around value-based care and risk. And that's one of the areas that we are looking at. Not all providers, when they begin the journey on value-based care, are able to assume downside risk, especially safety net providers and those caring for more underserved populations. And so we want to be thinking about risk and reward at different levels depending on an organization's capabilities. The other issue is financial benchmarks. I think we spend a lot of, it actually makes me really happy to be here today and hearing the words patient outcomes and person-centered, and not just talking about benchmarks and all of those financial pieces that are really critical, but they're really complex. We've learned a lot over the last decade about the complexity of benchmarks in our models, target pricing, getting it right, and risk adjustment. And so over time, we know we need to be striking a balance on those financial benchmarks and those financial components of our models, so that we're bringing more people in while also generating savings and better outcomes. And then the last couple of lessons were really related to transformation. If we want broad-based transformation, we really need to be able to bring more payers in the United States into value-based payment. We need greater alignment. And then we want to be able to encourage lasting transformation. So as many of you know, some of you may not, we test new payment and delivery models, so they are not permanent. If they are successful, we have the opportunity to make them permanent parts of our Medicare and Medicaid programs. But to get that kind of lasting transformation, there are a lot of other things that we need to be measuring and paying attention to as well. And so those are really the high-level lessons that came out of our review that are really helping us chart that path forward. And at very high level, just talk about our 5 strategic objectives. The first one is to drive accountable care. And that's really, really using our advanced primary care models, our accountable care organization models, to bring those longitudinal accountable care relationships where providers are accountable for cost and quality to their patients. The second objective is advancing health equity. We really want to be looking, when we're designing models, at all the levers that we have available to us to advance equity. So quality measures, payment incentives, health equity plans. How do we help organizations identify the needs of their communities and then build those interventions and programs to address those needs? The third objective is supporting innovation. We're thinking a lot about data standardization, data access. Connectivity was a word that came up earlier today. Payment waivers and benefit enhancements that allow the delivery of that integrated care that we really want to see patients receive. The fourth is addressing affordability. In the US, we have a major affordability problem for many families, even those with insurance. This is a really big area of focus for CMS, is how do we advance affordability. That's also something we're looking at more closely through our models. And then the last is partnering to achieve system transformation. And there's a lot of moving parts in that piece of our objective, but the one that I'll focus on is beneficiary engagement and input. And we're really committed to gathering beneficiary perspective and input across the life cycle of our models, from ideation to implementation to evaluation. And I think that's really core to us being able to design models that hopefully are in creating a more person-centered health system. So I'll stop there and turn it back to you. But thank you all, and it's really wonderful to be here with so many folks that are on this journey to helping build this, health systems all over the world that are committed to patient-centered care.
Wonderful, thank you so much. Dana, you have a role quite linked to what Purva described. Your organization validates quality metrics. In a sense, you define what should be quality. But you have a history as well where alignment has been a key word. Would love to hear your thoughts on the topic.
Yeah, thank you so much. And I'll just also begin by saying how great it is to be here. I think I heard the number 50 people who were here 10 years ago. I was one of them, just down the street at the Charles Hotel. And it's just really nothing short of thrilling to see how ICHOM has grown and the contributions that you've made. And I know this next decade will be even more prolific, and look forward to what you'll do and ways that we might partner in doing that important work. So yeah, I'll speak both from my role leading NQF, but also, as you've pointed to, the role that I played while I was at Blue Cross Massachusetts in innovating a payment model that really helped to catalyze payment reform, including some of the CMMI programs that began about a decade ago. And so, with your founding question to us about the role of policy, I would say there is this tension that we have to continue to balance between innovation and alignment or standards. Now, when it comes to the measures, as you pointed to, NQF, we're entering our third decade, so a little over 20 years ago, NQF was created really to play that role for the United States at a moment where quality measurement was moving from being something that was largely confined to academic studies and clinical trials to something that would actually be used for real-world, high-stakes purposes like payment, like public reporting of provider or health plan performance, and even the use of measures to steer patients toward or away from certain providers using tiered network designs and select network designs and center of excellence models. And so at that moment, there was a recognition in the country, how will we know which measures are good enough to be used for those high stakes accountability purposes? And that really is the genesis of the founding of the National Quality Forum that I have the privilege to lead now. And I think for those 20 years, that purpose has proved very important. At the same time that we need those standards around measurement, I would say, and here I'll speak from my role when I was in a payer system, that you also need the flexibility about how to use those measures to drive the improvements that you want. And so I'll share two brief stories to illustrate where innovation, I think, has to play a role, and then where that alignment really can play a key role. So on the innovation side, it was 2007 when Blue Cross Massachusetts set out to develop a new payment model, and it ultimately became called the Alternative Quality Contract, the AQC. And that payment model was really designed to do two things: to slow the rate of growth in healthcare spending, while at the same time improving quality and outcomes. So we lumped the quality and outcomes together, so it wasn't the triple aim, it was the twin goals. And what we developed was a model that used a global population-based budget coupled with a very significant quality measure set that included patient experience, clinical process measures, and clinical outcome measures, both in the ambulatory and the hospital setting. And very importantly, created a very significant, I believe to this day, the most significant earning opportunity for performance on those measures. And what we saw as a result was both twin goals actually being achieved in a very significant way. A quite dramatic, unprecedented, really slowing of the rate of growth of healthcare spending, and at the same time, unprecedented unprecedented improvements in quality and even outcomes, even those things that at the time clinicians might say, I can't be held accountable for because they happen outside the four walls of my delivery system. But fortunately for Blue Cross Massachusetts, the early adopters of the AQC were visionary in their own right and said they wanted the outcome measures to actually count more than the process measures. And that really drove the thinking of, outside the box of how do you actually think about the individual patient and what stands between them and good outcomes. It's not going to be cookie cutter the same thing for every individual who comes in front of you. And so that ability to innovate was really critical, and ultimately that was a private, commercial payer creating results that influenced the development in CMS, in CMMI's programs of its ACO programs and then other private sector payers. So a point where, not having standards and allowing innovation was critically important. On the other hand, when it comes to the measures themselves, we've really seen that if every payer is doing their own thing, that it really creates chaos within the delivery system in terms of where's the signal, what am I supposed to focus on? And there again, I would say is part of the value of the role that NQF plays in which measures are good enough. But even at that, with that, what we found when I was at Blue Cross was NQF wasn't feeding outcome measures, at least not at the pace and with the range that I needed from my seat at Blue Cross. So we said, let us be innovators in that space. I had a background, 16 years as a measure developer, patient-reported measures. So we got to work with our network to develop the next generation of measures that would use patient-reported information and fill important gaps. Well, it turned out that was an area of innovation that's very hard to do as one stakeholder. And so from where I sit now, I think that alignment around innovation, alignment around what are some of the most important gaps, and can we accelerate progress toward measures that fill those gaps? Some of the things that immediately come up are, behavioral health, both measures of access, but also importantly measures of outcome, obstetrics, cardiovascular procedures, new measures of patient experience are very high priority. Health equity measures have been a very, very high priority. Oncology outcome measures. So it's not an infinite list, and it's in fact a list for which ICHOM has some sets kind of ready-made that may really support this work. But I hope that's a helpful starter to the rest of this conversation about how we need to balance between allowing innovation but also knowing when alignment is going to help us make progress.
Right. Thank you, that's excellent. Very interesting examples, I think. I'd like to ask a question to Ernst, which I also think connects well to Purva. And Ernst, when you and I spoke, you were recently the CEO of the largest university hospital. And so my question to you was, you're now the minister and you're driving change top down. Yeah. Were you hoping for a more active minister when you were the head of the hospital, or the other way around, that you'd rather want them to stay away?
I thought you were going to ask, why would you ever want to become a Minister of Health? But you saved me that question, right? No, actually, see, in the Netherlands, we have what we generally think a wonderful healthcare system. It's based almost completely on public funding, equal access to everybody, irrespective of whether you have a job, whether you have an income, and then delivered by private institutes. But that's many of them. If you look for a total population of 18 million people, 1/8, we have approximately 20,000 individual healthcare providers, from single practice primary care to indeed Erasmus Medical Center as the largest one on the other end, and everything in between. And it used to be that government took a role very much sitting in the back row of the audience, just only determining overall budgets and what was to be reimbursed and what not. But other than that, take no specific action. And it's been my ambition and my role to really change that. and to take a much more active role from government. That's something that I thought also in a previous role, Stefan, in response to your question, that government should have done and could have done already many years ago. But if you just look at the challenges, and I hear this from all over, from Singapore, from Basque Country, North America, there are so many changes that are needed in healthcare due to the aging population, due to the fact that we can do more, that there are more and more opportunities, but also due to the complexity and the shortages in workforce, which is also very marked here, that really ask for a stronger role from government. Now, if I can give you just one or two examples. One is that our healthcare system traditionally has always been based on very strong primary care. However, primary care is under very significant pressure at the moment, and so what government and a minister can do is strengthen primary care in many different ways. For instance, by setting up and making a law, which we have just defended in Parliament and which has been accepted first in Parliament. We need to do another step on terms of data exchange and interoperability of systems from primary care to hospital to mental care, etc. Another one is setting up regional care coordination centers, which have real-time 24/7 insight in numbers of patients, demand, but also available capacity across all the domains of healthcare in a particular region, and thus also facilitating, and obviously very strongly coupling that and combining that with quality measures and patient experience. It's just two examples. I could give many, many others, but it really demands a different role from a ministry and from a minister. Thank you, Stefan.
I'd like to make a connection between what you said, Dana, and Purva, the experimentation that you're doing. Because I think what you're saying is that if we have too many, all payers have their own metrics, it will be chaos for the providers. But then the question is, who does that coordination? I mean, you could have Blue Cross Blue Shield talk to Humana, talk to United, and they can sit down and do it. Or CMMI, or the government does it together with NQF. But either way, you need somebody to put the stick in the ground and say, this is what we're going to measure. That means doing what Ernst described, is to have the government actually step forward much more and take a more active and decisive role, which in some healthcare systems, which are complex and heterogeneous and where everything is competition, may be seen as infringing upon the freedom of the market economy. How do you see, Purva, given the 10-year of experience you've had and the example that Dana showed, that CMMI, but more important, I think CMS, will take a more enforcing role when it comes to, for instance, payment models than in the past?
I think that's a really good question. You know, I view, well, first, CMS has, you know, a vision and a strategy that our administrators put forward, and our job is really, as the innovators at CMS, to help execute on that strategy. On the measurement issue, I'll say, you know, we have a national quality strategy that was released last April. There's a lot of work going on internally at CMS that hopefully we'll be able to share more on in the coming months around, you know, alignment on quality measures. You know, our role as a disruptor means that we often have to, our job is really to identify those innovation gaps and to be able to bring stakeholders along in the US system to test those models and to test in areas where there are innovation gaps for patients. And that means that we have to partner. So oftentimes, yeah, we can test a model, it puts a strong signal out, but we also want it to be implementable. And so on the front end, we are really trying to work more closely with providers, with health systems, with payers, with NQF, other experts, to make sure that we are designing models in a way that brings people to the table. I think one of the questions you're also thinking about is, you know, what we've learned from our voluntary models. Most of our models have been voluntary. We have done a handful in the mandatory space, and that's obviously something we have to continue to think about, but it's always balancing that with the need to make sure that we're also thinking about quality and equity and the other objectives that we have to balance as part of our strategy and the vision.
I'd like to ask a final question to the panel and then open up for one or two questions from the audience. And the topic I think all of you have mentioned is the HR challenge, or the people's challenge in healthcare today. And one can argue, I think, that COVID made things worse. But I would argue there were a lot of publications on doctor-nurse burnout and so on and so forth before COVID, and COVID made it worse. Now, would you say that that's a challenge in isolation? And we spoke before about we haven't had enough students in medical school and therefore we have a lack of doctors. Or is it more fundamental than that? And my question is really the value crisis, which is we actually don't know, most cases, whether what we do helps patients properly. We spend 20 to 40% on stuff that doesn't help patients. Is the people crisis and the value crisis two sides of the same coin? Or are they fundamentally different? Our hypothesis, my hypothesis has been, it's actually two sides of the same coin. Because we push everybody to run faster, because the economy is worse, we're in a downward spiral. And we need to take that fundamental rethinking of healthcare. What's your view? Do you share that the people's crisis is very much connected to the value crisis of healthcare and the challenge we have economically?
Well, I agree absolutely that it's the same coin with two sides, of course. And as we were just commenting when we were previous to this meeting, I think that the society has changed, and the public health services, I speak from my point of view, which is the public service, are not being able to advance at the same speed as the society is changing. And when I am talking about changing, I'm not talking about only technical changes, but the way of living, the way of thinking, and something that we are experiencing in our public health system is the way of understanding public service, which is pretty different from the one that was used 40 years ago when our public health system started. Everybody was so proud. Everybody was so happy of being part of that revolution that was starting with a new health public system with quality, high standards of quality, excellence, looking for the excellence. Nowadays, where there's a lack, there is a kind of sadness inside our professionals. Maybe one of the points is that we have less professionals that are going to come into the system, so they are feeling on their shoulders, the responsibility of trying to maintain as long as possible, together with being actualized every time because patients are more informed. New therapies require a lot of effort from our professionals, and everything is becoming more and more complicated.
I have a red 0 in front of me. I assume that means that we are over time. I think we could discuss this topic for another half hour. I hope to get a chance to discuss with you, and you all get a chance to discuss with the panelists. But I will be bold enough to still ask, I'd like one question from the audience. Who's the fastest to stand up and grab the microphone? It's really hard to choose among all the hands. Here's one.
This question may take more than a minute, but a question for my U.S. colleagues, and then maybe some input from those who are overseas. To what extent is the government, either CMS in their role as funding graduate medical education, or states in their role of funding undergraduate medical education, trying to transform the training of our clinicians from day one through their graduation and their practice?
That's a great question.
Yeah, I'm happy to give it a try. Our GME program is handled by, unfortunately, other colleagues at CMS. But I will say the workforce issues and the number of folks that are coming in to talk to us about the link between innovation and value and training, that number is increasing. And so I think at the Innovation Center, it's made us more aware of all of the workforce challenges and the pipeline issues and the training challenges. And so what we're trying to do is work more closely with our colleagues across CMS, our colleagues at the Health Resources and Services Administration and other parts of the Department of Health and Human Services to identify ways that, if we are testing value-based care models, we're thinking about value-based care, how does that also support a more resilient workforce? Because I think we have seen, especially through, COVID, that those, and for instance, primary care practices that were receiving population-based payments that were in value-based care arrangements were more resilient. They were able to stay open. They were able to deliver care to their patients and experienced, in some cases, less burnout as well. And so I think we'd like to think about ways that value-based care and value-based payment arrangements hopefully can be part of the solution, a longer-term solution to some of our healthcare workforce issues.
That question is a great segue to the next section, because the next section will be led by Elizabeth Teisberg, who wrote the book, The Basis for All of Us Being Here, but is also a teacher who engages in training the next generation to train young medical doctors and others to understand value-based healthcare from the start. So I don't know where Elizabeth is. She's close to here, I hope. Oh, there's a break first. That's wonderful. There is a break for everybody. Network, engage, and please come back in a few minutes for the next session. Thank you to the panel.